At EHA, this presented an updated analysis of the LINKER-MM1 study. This is a study that's testing a bispecific BCMA antibody in relapsed refractory multiple myeloma. So in the LINKER-MM1 study, the BCMA CD3 bispecific antibody Linvoseltamab was tested in patients with relapsed refractory multiple myeloma. The patients were heavily pretreated. The majority of the patients were triple-class refractory. The patients received 200 milligrams IV of a weekly schedule. Patients received from week 1 to week 14 the medication every week. Then it was followed by a bi-weekly application. And patients who achieved a VGPR or better had the option to go on a monthly treatment starting with week 24. So the primary objective of this study was overall response rate. And the median age of that population was an older one. So in median, patients were 70 years old, but we had around 26% of the patients over 75. Also, patients were heavily pretreated with over 80% triple-class refractory patients. High-risk patients around 40%, and ISS stage 3, 18%, and also extramedullary multiple myeloma occurred in 16% of the patients. Altogether, we treated 117 patients, and the overall response rate was very high with 71%. The VGPR was 50% of the patients, and patients who achieved a CR had in 93% of the cases an MRD negativity, which is excellent. That means once patients achieved a response, it was usually very deep. We also did a subgroup analysis, and we could see that especially patients who were older, over 75, high-risk multiple myeloma, extramedullary multiple myeloma, and triple-class refractory patients benefited from that clinical trial. So I mentioned already the median follow-up was 14 months, and we did not see that the median PFS and OS was achieved for all patients. So the median time to response was relatively fast. Patients achieved a partial response within a month and a VGPR within 2.6 months. Also, at the time of analysis, the PFS and OS was not reached. There was an analysis with a 12-month data cutoff, and the overall response rate at 12 months was not reached for the entire patient population, and it was 75% PFS for the entire patient population. With the bispecifics, we are especially interested in the CRS, cytokine release syndrome, but it only occurred in 46% grade 1 and 2. So there were no grade 4 CRS, and only few patients had a grade 3 CRS. Another problem which occurs with bispecific antibodies is a high infection rate. We observed that 75% of the patients had an infection, 36% had a grade 3-4 infection. So all patients received appropriate prophylaxis. And what we observed with appropriate prophylaxis and also IVIG, intravenous immunoglobulin application, that the risk for infection decreased. Actually, the grade 3-4 infection rate was 21% in the first 3 months, and it decreased to 6.6% after 1 year of treatment. So altogether, what we reported here is a high response rate of our patients with 70%, a very convenient schedule with a monthly schedule. Also, in terms of CRS, it was very well tolerated. Infection rate is still high, and we need appropriate prophylaxis. But the good news is that we observed also a decrease of the infection rate over the time of treatment. The significance of the results is that we have a monoclonal antibody that is well tolerated and can be given monthly. So I think that's very convenient for our patients, that once you achieved a CR or a VGPR, the schedule is much more convenient with really every 4-week infusion. We could also see that with appropriate management, that means antibiotic prophylaxis and IVIG, the infection risk really decreased to 6.6% for grade 3 and 4 infection, which is an excellent, and means that we really have to monitor those patients and have to treat infections very early. and all patients, of course, need an infectious prophylaxis.